You've faced that critical moment, haven't you? Standing at the bedside or maybe looking down at your work during a procedure, seeing that graft or flap that just isn't, well, it isn't performing as expected.
Yeah.
It's pale or dusky, maybe looks a little congested, and that feeling of urgency just kicks in. The clock is ticking. This needs intervention for potential salvage. It's one of the most challenging kind of high-stakes scenarios for any reconstructive surgeon.
Absolutely. I mean, the success of our reconstructive procedures really hinges on the viability of the tissues we use. And when that's threatened, it impacts, well, pretty much everything: the immediate outcome, the patient's whole healing trajectory, the potential need for more complex surgeries down the line.
And ultimately their function and appearance, right?
Exactly. Long-term function, appearance, the whole picture.
And that's precisely why today we're doing a deep dive into a powerful adjunctive tool that's in your armamentarium for these various situations. Hyperbaric oxygen therapy for those compromised grafts and flaps. We know that as specialist clinicians, you're constantly navigating these complex wound healing challenges, intricate reconstructions. So understanding the robust evidence behind the therapeutic options available to you in those critical moments is, well, it's absolutely paramount.
That's right. Our goal today is to really unpack the expensive body of evidence that supports using hyperbaric oxygen therapy, specifically in these challenging, compromised situations. We'll start by looking at the foundational stuff, the basic science, the animal studies. Now, okay, they sit lower on the evidence pyramid, but they offer these crucial insights into the underlying mechanisms, like how this therapy actually works at a cellular level, at the microcirculatory level.
Okay, so starting with the mechanisms and then building on that foundation.
Yeah, building on that, we'll move into the landscape of clinical evidence. We'll explore the studies, kind of categorizing them by their level of rigor, starting from the highest level, level 1 down through level 2, and also looking at the really valuable real-world insights we get from level 4 evidence, like case series and case reports.
Got it. Levels 1 through 4.
And then finally, we'll try and bring it all together by discussing the practical aspects, things like patient selection, clinical management, all based on what the available data tells us. We'll look at, when should you consider hyperbaric oxygen therapy, who's most likely to benefit, and how is it typically implemented in practice.
So our mission for this deep dive is pretty clear: to provide you, our listener, with a comprehensive, really detailed look at exactly what the sources tell us about when, why, and how hyperbaric oxygen therapy can be a crucial part of your strategy for maximizing viability and hopefully salvaging those compromised tissues. Let's unpack this important topic.
Okay, let's dive in.
So grafts and flaps, they're truly fundamental building blocks for us as reconstructive surgeons, aren't they? I mean, they're integral tools we use every day to restore form, restore function. But as you noted, success isn't always a guarantee, even with the best planning and technique.
That's correct. There are definitely specific situations where these reconstructive efforts can face significant compromise, and that demands urgent intervention for salvage. The source material details several of these critical scenarios, and just recognizing them is really the first step in figuring out if hyperbaric oxygen therapy might be applicable.
What are some of those specific situations then? What makes these tissues or the wound beds themselves so challenging?
Well, one major challenge we often face is working with tissues that have been previously damaged, particularly irradiated tissues or otherwise hypoxic wound beds. Radiation therapy causes this irreversible microvascular damage and fibrosis.
Right, that scarring.
Exactly. And it leads to tissue with significantly reduced oxygen delivery, impaired healing capacity. So these beds are inherently low in oxygen. They're hypoxic, which makes successfully integrating a new graft or flap profoundly difficult.
Because the native tissue just can't adequately support the metabolic demands of that transfer tissue. Doesn't have the plumbing.
Precisely. That's a good way to put it. Another situation involves the tissue we harvest itself. Say, when we take a skin graft, or especially a composite graft that has multiple tissue types, the size of the graft we've harvested can sometimes exceed the immediate ability of the recipient bed to nourish it. A larger graft just has higher metabolic needs, right? And its initial survival depends on soaking up nutrients and oxygen from the bed, that process called plasmatic imbibition. If that supply isn't sufficient for the graft size, parts of it just become hypoxic. Think of it like like a sponge that's too big for the amount of water it can soak up from the surface it's sitting on.
That makes sense.
Yeah.
And flaps, even though they bring their own blood supply, they can still run into trouble.
Oh, absolutely. Flaps face different potential issues. In random flaps, the ones relying on the subdermal plexus, there's that inherent limitation tied to their geometry. If they're too long relative to their width, the furthest portion just doesn't get enough blood flow. That's your classic random flap ischemia. But even sophisticated flaps, like pedicle flaps with a dedicated blood vessel, or even completely detached free flaps where we surgically connect their vessels, they can face compromise too. This often stems from issues with the blood supply itself, things like venous congestion where outflow is blocked, or arterial occlusion where inflow is stopped. And this can be due to technical problems, maybe clotting, sometimes even just external pressure.
And then there's that whole cascade of damage that can happen paradoxically right after you restore blood flow.
Ischemia reperfusion injury.
Yes, ischemia reperfusion injury, or IR injury.
Yeah.
That's a major issue, particularly in free tissue transfers. When blood flow returns to tissue that's been oxygen deprived, it triggers this complex inflammatory response and generates these harmful molecules, reactive oxygen species. And this can counterintuitively damage the tissue further after the period of ischemia. It's a real challenge.
And sometimes the compromise is set up even before the reconstruction begins, from the initial injury itself. Precisely. Trauma itself can result in tissue that's already compromised right from the start. Think about severe crush injuries or extensive degloving injuries where skin and soft tissue are basically stripped away.
Nasty stuff.
Yeah, or open fractures where the surrounding skin is poorly perfused just due to the severity of the underlying damage. All these scenarios create these challenging, often hypoxic environments from the outset, which predisposes any subsequent graft or flap to compromise.
So it's really in these specific compromise scenarios that the source material positions hyperbaric oxygen therapy as a useful adjunct. And that word adjunct seems really important here.
It is critically important. The sources are very clear on this. Hyperbaric oxygen therapy is neither necessary nor recommended for the support of normal, uncompromised grafts or flaps. If you've got a healthy recipient bed and a flap with perfect perfusion, or an appropriately sized graft that's taking well, you shouldn't need hyperbaric oxygen therapy. The rationale for its use is entirely specific to tissue that is already struggling.
Okay, so why is it useful only in that compromised tissue? What's happening physiologically that makes the difference?
Well, the benefit comes from dramatically increasing the partial pressure of oxygen in the patient's blood and, consequently, in the tissues. When you're breathing 100% oxygen under pressure, say at 2 or 2.5 atmospheres absolutely, you dissolve a significant amount of oxygen directly into the plasma. It's not just carried by hemoglobin anymore.
It bypasses the normal red blood cell limitation to some extent.
Exactly. This super-oxygenated plasma can then diffuse much further into areas where the normal circulation is impaired, those areas that are hypoxic. So in tissue compromised by conditions like irradiation, decreased perfusion, general hypoxia, or traumatic injury, this significantly increased oxygen gradient helps to, well, maximize the viability of that struggling tissue. It effectively delivers oxygen into areas that the native circulation just can't reach effectively.
And the downstream outcome of that increased oxygen delivery, what does that achieve?
By providing that crucial oxygen, you help prevent or at least reduce the amount of irreversible cell death necrosis in the compromised area. And this, in turn, can significantly reduce the need for regrafting or repeat flap procedures. And as you know, those additional surgeries add significant complexity, cost, and definitely morbidity for our patients.
The sources also strongly emphasize something critical about when this therapy should be initiated. It seems to come up again and again.
Yes. That's a key takeaway highlighted repeatedly throughout the literature. It's the importance of expedient initiation of hyperbaric oxygen therapy as soon, really, as graft or flap compromise is identified. Initiating the therapy promptly, ideally within hours of recognizing the issue, is what maximizes tissue viability. You're essentially delivering that crucial oxygen to the compromised cells before they reach the point of no return, before they die. This rapid response is fundamental to ultimately achieving graft or flap salvage. Time is truly tissue in these scenarios.
Okay, so we've established the why. It's for compromised tissue struggling with oxygen delivery. Now, how do we identify the proper patients and the underlying cause to ensure we're using this tool effectively? You mentioned it's not for everyone.
Right. Selecting the right patients is crucial for a successful outcome with adjunctive hyperbaric oxygen therapy. It's definitely not a blanket treatment. The source material emphasizes that identifying the underlying cause of the graft or flap compromise is vital. This diagnosis helps us determine the appropriate overall clinical management strategy and, importantly, whether hyperbaric oxygen therapy is indicated and how it should be used alongside maybe other interventions.
So understanding the specific problem really guides the potential solution.
Exactly. While studies have shown efficacy in, enhancing flap and graft survival in various experimental and clinical settings, hyperbaric oxygen therapy is indicated only in certain pathologic disorders or specific types of compromise that underlie the tissue's struggle. It's targeted.
Let's clarify the distinction then between compromised skin grafts or composite grafts and compromised flaps, looking at it physiologically. They start from fundamentally different places, don't they?
They do, and this difference is key to understanding how HbO2 might help. While clinically we might lump them together sometimes, compromised grafts are distinctly different from compromised flaps physiologically. Skin grafts and composite grafts are essentially avascular tissues at the time of transfer. They have no blood supply of their own initially. They rely entirely on the quality of the recipient bed for survival.
How does that work initially?
Initially, it's through that process we mentioned, plasmatic imbibition, basically soaking up nutrients and oxygen directly from the bed fluid. And then over the next few days, blood vessels need to grow into the graft from the bed. That's neovascularization or revascularization.
So the health and the oxygenation of the bed itself dictates the graft's survival prospects.
Precisely. Because of this complete dependence on the recipient bed, diagnosing a compromised graft really begins with a thorough assessment of the recipient wound bed. You have to ask, is it infected? Is it heavily scarred or maybe previously irradiated? Is it poorly perfused due to underlying disease or the initial trauma?
And the most effective strategy for graft compromise, as the source points out, is often trying to avoid it in the first place.
That's the ideal scenario, isn't it? The most effective solution is indeed prevention. Ensuring you have an appropriate recipient bed for the size and type of graft you plan to use before you even harvest it. By optimizing the bed, maybe through debridement, wound vac, or even pre-treating with HbO2 in some cases like radiation damage, you significantly increase the chances of successful graft take and potentially avoid the compromise altogether.
But despite careful planning, compromise can still happen with grafts. Things don't always go perfectly.
It certainly can. There are times when maybe a subtle issue with the recipient bed goes unrecognized, or maybe the size of the harvested graft just exceeds the dimensions the bed can realistically support through that initial diffusion and eventual vessel ingrowth. Think about traumatic avulsions of soft tissues like parts of the nose or the ear or fingertips, which might be treated with composite grafts. These are often challenging.
Right.
Or cases where maybe surgical planning or judgment leads to attempting excessively large composite grafts on a bed that simply cannot sustain them metabolically. These compromised grafts become hypoxic because the oxygen supply from the bed just isn't sufficient.
And this is where hyperbaric oxygen therapy comes into the picture, specifically for grafts.
Yes. These specific types of compromised grafts may be salvaged with the prompt institution of hyperbaric oxygen therapy. By significantly increasing tissue oxygen levels, HbO2 can help maximize the viability of that struggling graft tissue while revascularization from the bed takes place. It essentially buys time for the bed's blood supply to grow into the graft. This helps reduce the area of necrosis and therefore reduces the need for repeat grafting procedures, which, as we said, means avoiding additional operations and minimizing donor site morbidity for the patient.
Okay, that's clear for grafts. It's about supporting them while the bed catches up. Now, what about the many potential causes, the etiologies of flap compromise? They have their own blood supply, so what goes wrong there?
Flap compromise can stem from numerous causes. This includes random ischemia, particularly in larger or less ideally designed random flaps where the blood supply simply tapers off distally. It can also be due to more discrete issues affecting the blood vessels, like venous congestion or even total venous occlusion leading to impaired outflow of blood.
So it gets backed up.
Exactly, it gets dusky and swollen. Or, conversely, arterial occlusion affecting inflow, so it looks pale and cool. And even flaps that were meticulously designed and transferred can face problems like vasospasm or thrombosis, clotting after the surgery.
And trauma, again, can directly impact flaps.
Absolutely. Traumatic injuries can result in significant avulsion of soft tissues, causing direct damage to the vessels within the flap itself. Those extensive degloving injuries can disrupt the subdermal plexus that's essential for skin flap survival. And open fractures often involve overlying skin flaps that are poorly perfused simply because of the severity of the underlying bone and soft tissue damage.
Free tissue transfers, the ones involving microsurgery, introduce yet another layer of potential issues, don't they?
They do. Free flaps require dividing and then reattaching their blood vessels, their artery and vein, using microsurgical techniques. Because of this process, they are inherently exposed to the risk of ischemia reperfusion injury when blood flow is restored. And then they can potentially face secondary ischemic insults if those tiny anastomoses, the connections, clot off or suffer compression postoperatively. These issues can severely compromise their viability very quickly.
In many flap-compromised cases, the immediate response involves heading back to the operating room, right?
Yes, in a significant number of cases, surgical re-exploration is the first and most crucial step. This allows the surgeon to directly identify and, hopefully, treat the mechanical cause of the flap compromise. That might mean releasing tension or compression, maybe untwisting a kinked pedicle, or revising a thrombosed arterial or venous anastomosis. Fixing the plumbing, if you will, is paramount if a mechanical problem exists.
But there are those challenging situations where you explore and there isn't a correctable mechanical cause found. Or maybe the issue is more diffuse.
That's a particularly difficult scenario. In some instances, despite re-exploration, no correctable mechanical cause of the decreased flap perfusion is identified. This might be the result of diffuse damage from a severe crush injury to the flap tissue itself, where the microcirculation is just generally impaired. Or it might be an inherently large random flap that simply does not follow the classic 3-to-1 length-to-width ratio, leading to inadequate blood supply to the distal portion right from the start, regardless of the main pedicle.
So if you can't fix the plumbing surgically, or the problem isn't the main plumbing, that's when hyperbaric oxygen therapy becomes highly relevant for flaps.
Precisely. In these cases where a mechanical fix isn't possible or isn't the primary issue, hyperbaric oxygen therapy can play an important role in flap salvage. Similar to grafts, the key to maximizing the chance of salvage is prompt institution of hyperbaric oxygen therapy. By starting quickly, you help maximize the viability of that compromised tissue. You're potentially buying time for the tissue to recover, maybe for collateral circulation to develop, or for other intrinsic healing mechanisms to kick in and overcome the insult.
And the overall benefit mirrors what we discussed for grafts, reducing further surgery.
Yes, exactly. By reducing the area of necrosis in a compromised flap, hyperbaric oxygen therapy can reduce the need for repeat flap procedures, minimize the extent of surgical debridement required later, and thus decrease the overall patient morbidity and the burden, both physical and financial, of additional surgeries.
Okay, we've covered the problem scenarios pretty well, the types of compromise, and the patients who might benefit those with compromised tissue where oxygen delivery is the issue. Now let's really dig into the evidence that supports using hyperbaric oxygen therapy in these specific situations.
Right. The evidence base for hyperbaric oxygen therapy in compromised grafts and flaps comes from, well, a combination of experimental studies, mostly in animals, and clinical data from human patients. And these studies are typically classified by their level of rigor, often using systems like the Oxford Center for Evidence-Based Medicine.
The sources mention Figure 1, which visually represents this hierarchy of evidence. Can you describe that briefly for our listeners?
Sure. Figure 1 is essentially that classic pyramid shape you often see in evidence-based medicine. At the very bottom, you have level 5 evidence, which includes things like basic science research, animal studies, expert opinion, mechanistic reasoning, foundational, but less directly applicable to clinical outcomes. As you move up, you get level 4, which is typically case series or case reports observations in groups of patients without a control group. Then level 3 might be case control studies. Level 2 includes cohort studies, like comparing groups with and without treatment but not randomized, and maybe smaller or lower quality randomized trials. And right at the top, the peak, is level 1 evidence. Large, well-designed, randomized controlled trials and systematic reviews or meta-analyses of those trials. That's considered the highest level of evidence for guiding clinical practice.
Got it. And Figure 2 in the source material summarizes the available clinical evidence specifically for HBOT in grafts and flaps using these levels.
That's right. Figure 2 gives a snapshot. It indicates there is level 1 evidence, specifically from that single randomized trial by parents we'll discuss, which focused on grafts and included 48 patients. Then there's level 2 evidence coming from 2 main sources mentioned, the Roche et al. Cohort study in trauma patients, and the Zhu et al. Review, which pulled data from multiple smaller trials, altogether encompassing nearly 2,000 patients across those studies contributing level 2 data. And finally, there's extensive level 4 evidence from numerous case series and retrospective reviews covering thousands of grafts and flaps across various clinical settings.
Okay, let's start where the science often begins in the lab, with the foundational insights from the animal studies. Level 5 evidence.
Right. Now, although basic science and animal studies are classified as level 5 evidence and perhaps aren't valued quite as highly for direct clinical decision-making as they once were compared to human trials, they remain invaluable. They really offer one of the best scientific methods we have to obtain controlled experimental data, to isolate variables, and especially to explore the underlying physiological and cellular mechanisms in detail, things you simply can't do invasively in human patients.
And the source notes that the real power of these animal studies for this specific application isn't just the sheer number of experiments conducted, but the remarkable consistency of the findings and the mechanistic insights they provide.
Exactly. What's really compelling when you look at the animal literature is the overwhelmingly positive results demonstrated across many different models, different species, different types of flaps and grafts. And crucially, the clarity these studies provide on the cellular and physiological pathways, how hyperbaric oxygen therapy actually benefits compromised tissue, how it affects microcirculation, inflammation, angiogenesis, how it mitigates damage like ischemia or reperfusion injury. They provide that essential basic science underpinning for the clinical application.
Okay, let's look at what some of these key animal studies actually showed. Maybe we can group them by the kind of problem they were trying to address, starting with just basic wound healing and graft take on compromised beds.
Sure, studies like the one by Kibasari and Ninakoski in rats are interesting. They looked at HbO2 on both compromised and non-compromised wounds. They found that hyperbaric oxygen therapy at 2 atmospheres absolute had no effect on the healing rate of normal open wounds where circulation was intact. However, on wound edges that were deliberately devascularized, simulating a compromised state, HbO2 therapy significantly enhanced the wound closure rates compared to control groups. That really highlights the distinction. The benefit seems specific to compromised, poorly perfused tissue.
That's a key point. What about Schulman and Crone?
Schulman and Crone, also in rats, studied full-thickness and partial-thickness wounds. They found HbO2 significantly shortened healing time overall. And interestingly, they found that the combination of repeated skin grafting and HbO2 therapy actually reduced the healing time of partial-thickness wounds to about 1/2 of that seen in non-treated controls. They also made a side observation that while minimal superficial contamination occurred, significant infection was entirely absent in the groups treated with HbO2, hinting at a potential anti-infective benefit in that specific model.
So positive effects even on just wound beds or partial grafts. What about survival of full-thickness skin grafts or composite grafts?
Yeah, multiple studies explored this. Erdmann et al., in mice, for instance, used a mouse skin allograft rejection model. They found that treatment with hyperbaric oxygen therapy, either alone or in combination with cyclosporine, actually lengthened the time it took for the allograft to be rejected. And this effect was more profound in animals that received more frequent HbO2 therapy compared to less frequent treatments. It sort of suggests HbO2 might improve the overall tissue health in a way that perhaps mitigates some aspects of the immune response, though that's complex.
Interesting. And studies looking at composite grafts like ear reconstructions.
Yes, Renner et al. And Rubin et al. Both used rabbit models, specifically looking at reattached auricular composite grafts relevant for facial trauma reconstruction. Rubin et al.'s studies showed that grafts in the HbO2-treated animals demonstrated significantly greater survival than the controls. Zhang et al., also using rabbit ears, found HbO2 therapy significantly increased the survival area of composite skin grafts compared to controls, showing a difference of about 82% survival versus only 26.5% in controls. A pretty dramatic difference.
Wow. And did graft size seem to matter in these studies? You mentioned that earlier regarding metabolic demand.
Yes, that's a really key finding that comes out of the animal work, like at all. Specifically investigated this in rabbits, looking at composite graft survival of different sizes, 0.5 centimeter, 1 centimeter, and 2 centimeters. They found that the largest grafts, the 2 centimeter ones, treated with HbO2 had a mean graft survival rate of about 86%, compared to only 51% in the control group for that size. But importantly, they saw no significant benefit in the smaller 0.5 centimeter or 1 centimeter grafts.
So that strongly suggests the benefit is most pronounced for larger grafts.
Exactly. Larger grafts are more likely to be inherently compromised and hypoxic simply due to their higher metabolic and oxygen requirements, exceeding the immediate support capacity of the recipient bed. Fodor et al. In rats studied relatively large 3 by 3 centimeter composite grafts. They also found a statistically significant improvement in survival, particularly on the internal surface of the graft, 62% versus 41%. Even though the external surface didn't show a significant difference, they suggested that preserving even just the deep layer could be valuable, providing a suitable bed for subsequent split-thickness skin grafting if needed. So, Salvaging a portion is still a win.
These findings consistently point towards a benefit in compromised grafts, especially the larger ones. But of flaps, there seems to be a lot of animal work on flaps too.
Yeah. Oh, yes, a huge amount. Some of the early studies by researchers like Gruber et al. And Yanikoski, back in the 70s using rats, demonstrated substantial benefits on experimental skin flaps, both random and tubed flaps. They reported a remarkable 51% improvement in the length of the viable portion of the flap with hyperbaric oxygen therapy compared to air-breathing controls. And Yanikoski's work was pivotal because it started to show how this might be happening. He demonstrated that HbO2 at 3 atmospheres absolute could raise tissue oxygen tensions up to 600 millimeters of mercury, whereas breathing 100% oxygen at sea level did not significantly raise the mean flap oxygen tension. That really highlights the physical principle, the increased dissolved oxygen achieved only under pressure.
So it's the pressure driving the oxygen further. Did other studies replicate these positive flap survival findings?
Yes, consistently. Pelletieri et al. Used a pig model with a standard random skin flap designed specifically to have predictable and significant necrosis. They found the HbO2 group demonstrated a mean survival of 77% compared to control animals, which had 35% necrosis, so a big reduction in tissue loss. Arterson and Kana and Escalmato et al., both using rat dorsal random skin flap models, also reported significant improvements in flap survival over untreated controls.
Escalmato's study compared HbO2 to other treatments.
That's right. They compared HbO2 to steroids and a combination. Interestingly, while all treatments showed some improvement, the best results were seen in the HbO2 only group, which showed about a 36% improvement in survival compared to controls. It highlights the efficacy of HbO2 as a standalone adjunct in that model.
And what about combining HbO2 with other agents, thinking mechanistically, like antioxidants?
Stewart et al. Showed a positive effect when they combined hyperbaric oxygen therapy with certain free radical scavengers, like superoxide dismutase or vitamin E, in increasing random skin flap survival. Each combination demonstrated significantly greater flap survival compared to controls, suggesting that part of HbO2's benefit might be in mitigating the oxidative stress associated with ischemia.
But not all combinations worked.
Interestingly, no. DeRocha et al., conversely, found that adding the antioxidant N-acetylcysteine, NAC, which is a precursor to glutathione, did not improve flap survival above and beyond what HbO2 therapy achieved alone in their model. Their best results were actually seen in the HbO2-only group, which also showed decreased molecular markers for apoptosis or programmed cell death. So it suggests not all antioxidant combinations are necessarily synergistic with HbO2, and HbO2 itself has powerful effects. Greenwood and Gilchrist also demonstrated HbO2 was effective in reducing the extent of ischemic necrosis in skin flaps.
Let's circle back to specific clinical challenges. Irradiated tissue beds were mentioned as particularly difficult. Did animal studies address this directly with flaps?
Yes, absolutely. The controlled study by Nemiroff and Lungu in rats specifically examined experimental random skin flaps elevated in irradiated tissue beds. They confirmed that irradiation significantly reduced flap survival, as expected. But importantly, they showed that administering hyperbaric oxygen therapy within 4 hours after flap elevation resulted in significantly greater flap survival time, as much as a 22% increase compared to irradiated controls without HbO2. This provided key preclinical evidence supporting HbO2 use in irradiated fields and, again, powerfully emphasized the critical importance of timing getting the treatment started early.
That timing element keeps popping up. What about comorbidities that affect healing, like diabetes or smoking? Did the animal models look at those?
They did. Zhang et al. Demonstrated beneficial effects of HbO2 in improving the survival of random pattern skin flaps in diabetic rats. They found significantly reduced necrosis in the diabetic rats treated with HbO2 compared to untreated diabetic controls. And then Selcook et al., and later Camargo et al., showed positive effects on random dorsal skin flap survival in rats that were either treated with nicotine or exposed to tobacco smoke. HbO2 significantly improved survival compared to the nicotine smoke exposed controls. This suggests HbO2 can play a role in increasing flap survival, even in cases where multiple factors are contributing to the flap compromise.
Okay, so beyond just showing that HbO2 improves survival percentages, the animal studies really seem to illuminate the mechanisms at play. What did they reveal about how HbO2 is working at the tissue level?
This is where the animal studies are incredibly valuable. Nemiroff and Lungu, in that same study, did microvascular analysis. They found that the number and the size of blood vessels within the microvasculature were significantly greater in the flaps from HbO2-treated groups compared to controls. They concluded this increased vascularity was a key mechanism by which HbO2 enhanced flap survival. And again, they stressed the need to administer it as soon as possible after surgery.
So more and bigger small blood vessels.
Exactly. And other investigators provided further evidence for this. Manson and Associates and Champion and colleagues proposed that HbO2 enhances graft and flap survival, at least in part, by promoting angiogenesis, the growth of new blood vessels into the ischemic tissue. Manson et al.'s work in pigs was particularly visual. They showed capillaries extending nearly 3 times further distally in HbO2-treated pedicle flaps compared to controls. Champion et al.'s work in rabbits also supported this angiogenic effect and attested to the value of HbO2 in preventing necrosis in a severe test system.
That image of capillaries reaching 3 times further is pretty compelling. What about timing again? We keep coming back to it, but the animal studies seem to consistently reinforce it.
They absolutely do. The study by Jarrell and Kaiser in rats using a cranially based pedicle flap specifically investigated the timing of initiation. They found a significant survival benefit with HbO2 compared to controls. But critically, they showed that while delaying the start of HbO2 by 24 hours still resulted in greater survival than controls, the increase in the surviving area was significantly greater if HbO2 treatment began immediately after the surgery. This study provided direct experimental proof for that start ASAP principle that's emphasized clinically.
And the need for pressure. It's not just about breathing high concentrations of oxygen, right?
Correct. That's another key takeaway from the basic science. Tan et al.'s study in rats looked at this directly. They found that giving hyperbaric oxygen at a concentration equivalent to breathing room air at standard pressure, about 8% oxygen at 2 atmospheres, exhibited no improvement in skin flap survival. However, hyperbaric treatment with 100% oxygen under pressure exhibited significant increases in survival. This confirms that it's the high partial pressure of oxygen, achieved only under hyperbaric conditions, that's essential for driving enough oxygen into the compromised tissue to make a difference.
What about specific types of flaps or more complex models of compromise like venous problems or combining therapies?
There were studies on various specific models. Ramon et al. Looked at tram pedicle flap skin paddles in rats relevant to breast reconstruction and showed HbO2 significantly improved survival after 8 hours of ischemia. Prada et al. Compared HbO2 to other agents like allopurinol and axial pattern flaps after warm ischemia and found HbO2 provided comparable benefit. Nemiroff et al. Demonstrated a really powerful synergistic benefit by combining HbO2 with contoxifylline, which is a rheologic agent that improves red blood cell flexibility and capillary circulation.
Right.
The combination resulted in significantly greater flap survival than either agent alone, an 86% improvement over controls versus only 30 to 40% with single agents.
So combining mechanisms can be better.
It seems so, at least in that model. Collins et al. Found a similar synergistic benefit combining HbO2 with nicotinamide on epigastric flaps. However, venous occlusion models were trickier. Lozano et al. Studied total venous occlusion in axial flaps in rats. They found that hyperbaric oxygen therapy alone was not an effective treatment for flaps compromised solely by total venous occlusion. The plumbing was just too blocked. But the combination of medicinal leaching, which helps mechanically drain the congested blood, plus HbO2 resulted in significantly improved flap survival compared to leaching alone. This suggests HbO2 doesn't fix the primary venous outflow problem, but it might enhance the tissue's tolerance or recovery when outflow is partially managed by other means, like leaching.
That's an important nuance.
Yes, and Usil and Beramici also noted the need for acute HbO2 support in their specific venous flap model. Olker et al. Even differentiated types of insufficiency, finding HbO2's beneficial effect was actually greatest in flaps compromised by arterial insufficiency compared to venous or combined insufficiency in their models.
Let's focus back on ischemia reperfusion injury for a moment.
Yeah.
You mentioned it's particularly relevant for free flaps. What did the animal studies show there?
IR injury is a major cause of compromise, and multiple experimental studies demonstrated beneficial effects of hyperbaric oxygen therapy in mitigating this specific type of damage in both skin and muscle flap models. A really key study here was by Zamboni et al. In rats. They subjected axial pattern skin flaps to prolonged ischemia and then looked at the effects of HbO2 given during ischemia, following ischemia, or during ischemia, but with the flap covered to prevent direct oxygen diffusion. They found that HbO2 administered either during or immediately following the period of total ischemia significantly reduced the amount of flap necrosis compared to controls.
Man, that was surprising at the time.
Yes, it was actually the opposite of the author's original hypothesis. They thought high oxygen during reperfusion might worsen oxidative stress, but instead it proved to be protective in their model. In follow-up work, they showed that HbO2 actually increased microvascular blood flow during the reperfusion phase compared to untreated ischemic controls, suggesting improved perfusion was part of the mechanism. Kalin et al. Also showed HbO2 during reperfusion improved free flap survival after long ischemia times.
And did studies get into the molecular mechanisms behind this protection against IR injury?
Yes, this is where the animal studies really shine, getting into molecular detail. Work by Jones et al., and later Benosa et al., using a skeletal muscle microcirculatory flap model of IR injury, provided fascinating insights. They observed that HbO2 given during or just after reperfusion significantly reduced neutrophil endothelial adherence in the small veins, the venules. Essentially, it stopped those inflammatory white blood cells, the neutrophils, from sticking to the blood vessel walls, which is a key early step in reperfusion damage.
How did it stop them sticking?
Their work linked this effect to the modulation of an adhesion molecule called CD18 on the neutrophils. Subsequent studies suggested these effects might be dependent on nitric oxide, produced via the nitric oxide synthase (NOS) pathway. Benosa et al. Proposed the benefits might result from an early increase in NOS activity, followed by a delayed increase in NON expression. They also implicated the vascular endothelial growth factor, VEGF, pathway in mediating these effects on neutrophil adhesion, so a complex interplay of signaling pathways.
Wow, detailed stuff. Any other molecular links?
Hong et al., looking at tram flaps after IR injury, also found a significant survival increase with HbO2 and suggested it might involve decreased expression of another adhesion molecule, ICM1, on the endothelial cells lining the blood vessels. And Tomura et al., focusing on the role of free oxygen radicals in IR injury, showed that HbO2, similar to an antioxidant vitamin combination, significantly increased flap survival after ischemia and reperfusion, reinforcing the idea that HbO2 helps counteract oxidative stress.
Okay, one last area from the animal studies. What about secondary ischemia? That situation where a flap survives the initial surgery, but then develops a problem later, like a clot.
Yes, that's clinically very important. Several studies looked at this. Stephen Slaughter's, in rats, used an axial skin flap model where they induced a primary ischemic period, then later a secondary ischemic insult of varying lengths. They found that the duration of secondary ischemia the flap could tolerate before 50% necrosis occurred was significantly increased from 6 hours in controls to 10 hours in the HbO2 group. It shows HbO2 can extend the tissue's tolerance to subsequent ischemic events.
So it makes the tissue more resilient.
It seems so. Wang et al. Quantified this in a muscle flap model. A primary 2-hour ischemia caused about 40% necrosis in controls, reduced to 24% by HbO2. Adding a secondary 2-hour ischemia dramatically increased necrosis in controls to 85%, but this was significantly reduced to 58% in the HbO2 group. Gemper et al. Looked specifically at secondary venous ischemia and also found HbO2 increased survival. Although they noted the timing relative to the secondary insult mattered, the protective effect might not last more than about 5 hours after an HbO2 treatment.
Okay, let's try a quick micro recap of this extensive animal data. It seems the lab studies consistently show HbO2 improves survival of compromised grafts and flaps across many different models: ischemia, irradiation, diabetes, nicotine exposure. They provide strong basic science support, pointing to mechanisms like improved microcirculation, boosted angiogenesis, enhanced oxygen diffusion into hypoxic zones, and importantly, modulation of inflammation and mitigation of ischemia reperfusion injury, particularly by affecting neutrophil adhesion and oxidative stress. And maybe the most consistent message across all these studies is the critical importance of prompt initiation starting treatment, ASAP, and the need for hyperbaric pressure to achieve the necessary high partial pressure of oxygen.
That's an excellent summary of the key findings from the foundational work in the lab. It really sets the stage for understanding why this therapy might work in humans. Now let's transition to the human data, the clinical studies.
Right, because ultimately, while animal models are informative, clinical data is paramount for guiding practice in evidence-based medicine. The source highlights that there's a considerable amount of clinical literature, over 28 studies cited, involving more than 2,300 patients, grafts, or flaps in total. And this clinical evidence ranges in quality from level 1 down to level 4, as we discussed with the evidence pyramid.
Exactly. And as shown again in Figure 2, the breakdown is roughly that single level 1 study by Perrins on compromised grafts, 48 patients, Level 2 evidence primarily from the Roja et al. Trauma cohort study and the Zhu et al. Review encompassing multiple trials, totaling around 1928 patients combined in those level 2 sources, and then extensive level 4 evidence from numerous case series and retrospective reviews adding thousands more observations.
Okay, let's start at the top then with the single level 1 study. This was by Perrins and colleagues.
Yes, Perrins and his team were real pioneers in this field. Building on some earlier work they did in the 1960s, they later conducted a proper, blinded, prospective, randomized controlled trial, specifically evaluating adjunctive hyperbaric oxygen therapy for compromised skin grafts. This study, published in The Lancet, included 48 patients, and remarkably, it remains the single level 1 prospective randomized controlled trial evaluating HBO2 specifically for compromised grafts even today.
Wow, just one. How was that trial structured, and what were its key findings?
Patients in the treatment group received hyperbaric oxygen therapy at 2.0 atmospheres absolute, which is standard pressure, for 90 minutes twice daily for 3 days, so 6 treatments total. Complete graft take was defined pretty stringently as greater than 95% survival of the graft surface area. The results were quite striking. The study demonstrated a significant 29% improvement in overall graft survival compared to the control group, with a p-value less than 0.01.
And in terms of complete survival?
Even more dramatic. Complete survival that greater than 95% take occurred in 64% of the HBO2 treated group versus only 17% of the controls. Again, highly statistically significant. Furthermore, 100% of the patients treated with HBO2 achieved at least 60% graft survival, compared to only 64% of the controls reaching that threshold. While the exact cause of compromise wasn't defined for every single patient, the very low success rates in the control group clearly showed these were genuinely compromised grafts, and the study strongly suggested that HBO2 significantly enhanced their healing.
That's a pretty powerful finding from the highest level of evidence, even if it's just one study focused on grafts. Okay, moving down slightly to level 2 evidence. The source points to a study by Roja et al. From 2008.
Right. Roja and colleagues conducted a level 2 study. Specifically, it was a retrospective controlled cohort study. They evaluated the effect of adjunctive hyperbaric oxygen therapy on short-term complications in patients undergoing reconstruction for traumatic extremity war injuries. A very challenging patient population. They looked at a total of 388 patients. 99 received HBO2 as an adjunct, and 289 served as controls. The HBO2 treatments were given at pressures between 2.2 and 2.8 atmospheres absolute, with the frequency and number of sessions varying based on the clinical scenario.
And what did they observe regarding graft and flap complications in these severe trauma cases? What outcomes did they measure?
They looked at several key complications: skin graft laces, failure, flap necrosis, soft tissue infection, and osteomyelitis. Their findings were significant. They showed a significantly higher incidence of both skin graft laces, 52% in the control group, versus only 23% in the HBO2 group, a huge difference, p0.001, and also flap necrosis, 51% in controls versus just 15% in the HBO2 group, again, 0.001. These represent substantial reductions in major reconstructive complications associated with the use of adjunctive HBO2 in this cohort.
That's impressive. Did they look at whether the severity of the initial injury made a difference?
Yes, they did a very important sub-analysis. They scrutinized their data and stratified the patients into 4 subgroups based on the severity of their injuries. Group 4 had the most severe injuries, often involving ischemia, compartment syndrome, complex soft tissue defects, and open fractures. Group 1 had relatively less severe injuries, though still significant, like complicated vessel or nerve injuries. This stratification demonstrated a statistically significant beneficial effect of hyperbaric oxygen therapy across each and every one of the injury severity groups.
So it helped even in the worst injuries?
Yes, that's the key takeaway. The benefit wasn't just limited to the less severe cases. HBO2 appeared to help preserve and salvage both compromised grafts and flaps, even in the context of very complex, high-energy traumatic injuries. It held true across the board.
Okay. The source also mentions a second level 2 contribution, a more recent review by Zhu et al. From 2022.
That's right. The Zhu et al. Paper is described as a level 2 study, but it's actually a large systematic review focusing on randomized controlled studies primarily from China, covering about 20 years of data. It pooled data from 23 clinical trials involving a total of 957 patients who received HBO2 and 583 control patients. So, nearly 2,000 patients contributing level 2 evidence in aggregate.
And what was the overall finding from pooling those trials?
The review reported survival rates in the HbO2 groups ranging from 62.5% up to 100%, compared to 35% up to 86.5% in the control groups across the various studies, so generally favoring HbO2. Importantly, the review authors noted that positive results seemed associated with initiating treatment less than 72 hours after surgery, once again providing clinical support for the importance of timing. However, they also cautioned about significant heterogeneity in the treatment times and regimens used across the studies, and noted that the sample sizes in most of the individual included trials were quite small.
So, supportive overall reinforces timing, but notes limitations in the underlying studies. Now, moving down to level 4 evidence, the case series and case reports. While they lack control groups, they offer valuable real-world insights, don't they?
Indeed, they do. They provide context and show how therapies are being used in practice, even if they can't prove causality in the same way. The source notes that several other case series, level 4 evidence, have been reported involving compromised grafts and flaps, and they consistently suggest a benefit across various types of reconstructions. For example, Gonerang et al. Reported using adjunctive HbO2 in 10 patients undergoing periorbital reconstruction. They demonstrated complete survival of 2 ischemic random flaps and 4 composite grafts, some quite large, with their protocol.
And Bowersox et al. Had a large series.
Yes, Bowersox and colleagues presented a significant series of 105 patients who had compromised grafts or ischemic skin flaps. Importantly, 90% of these patients had risk factors known to be poor prognostic indicators for healing, like diabetes or smoking. They used a protocol starting with twice-daily HbO2 at 2.0 atmospheres for 90 minutes, usually for 5 to 7 days, then transitioning to daily sessions once clinical improvement was noted, averaging about 16 treatments total. Their reported results were impressive. 89% of the compromised grafts and 91% of the threatened skin flaps were salvaged.
Wow, even in high-risk patients. And did their study shed light on timing again?
This is a crucial finding from the Bowersox study, providing strong clinical correlation to the animal data. They found that compromised flap failure was significantly associated with a delay in the initiation of hyperbaric oxygen therapy. The average time from surgery to starting HbO2 was almost 20 days, 19.8 days, for the flaps that ultimately failed, compared to just 4.6 days for the flaps that were successfully salvaged. That difference was highly statistically significant, 0.01, and serves as a very strong clinical indicator for prompt treatment initiation.
That's a clear clinical signal. Were there other case series reinforcing similar points or adding different perspectives?
Yes, several others. Ueda et al. Studied 26 compromised flaps and noted an average improvement in graft survival of 92.1% with HbO2. Mathieu et al., in a series of 15 pedicle flaps, brought in the concept of objective monitoring. They highlighted a positive correlation between transcutaneous oxygen tension TCM readings taken during HbO2 treatment and eventual flap success. They even defined a value of 50 millimeters of mercury measured at pressure as a critical cutoff for predicting success when deciding whether to continue treatment.
How reliable was that TCM cutoff?
According to their report, it was quite predictive. They noted that, indeed, all of the flaps in their series with TCM readings below 50 millimeters of mercury that did not increase above that level during an HbO2 challenge treatment ultimately failed. This suggests TCM can be a valuable objective assessment tool and potentially a predictor of response to therapy.
That's very useful clinically. What about Waterhouse et al.? They look specifically at free flaps and replantations, which are often more sensitive.
Yes, their study focused on 14 free flaps and 2 replantations, many compromised by prolonged ischemia, secondary ischemia, or radiation. They also demonstrated a clear benefit related to the time to initiation of HbO2. 89% of the patients treated within 24 hours of compromise being identified had complete salvage. However, the outcome was significantly worse with delay. One patient treated within 24 hours still had partial necrosis. Only 1 out of 4 flaps treated after 3 days was salvaged, and all flaps where HbO2 was initiated after 3 days post-op resulted in complete loss.
So the window is even tighter for free flaps and replants.
That's the implication. Free tissue transfer necrosis is a significant loss for both patient and surgeon. This study really underscored the rationale for initiating HbO2 therapy as soon as flap compromise appears, particularly in free flaps and replantations where the time to restore perfusion or support the tissue is much more critical. The cutoff for salvage appeared much shorter than what Bowersox observed for skin flaps, highlighting that tissue tolerance varies.
Are there more recent series confirming these trends?
Yes, Larson et al., in a 2015 series, retrospectively reviewed 15 patients treated with HbO2 for failing or threatened post-reconstructive flaps. They found that 11 out of 15, about 73%, improved, with 7 healing completely and others showing substantial improvement, averaging about 68% salvage of the flap area. Again, they noted successful outcomes seemed associated with patient compliance, the treatment regimen used, and significantly, pre-treatment transcutaneous oxygen levels, reinforcing the value of TSACOM and patient factors. Another case series from 2015 noted a similar success rate of around 76%.
And the source mentions numerous favorable case reports illustrating specific scenarios.
Exactly. There have been quite a few published case reports describing successful outcomes, which help illustrate the breadth of application. These include salvage of compromised composite grafts, like skin, subcutaneous tissue, and cartilage, in nasal reconstruction after trauma, successful salvage of flaps compromised by severe dog bites, like facial avulsions, and even a case of a complete scalp degloving injury treated successfully with adjunctive HbO2. There are also several reports demonstrating successful salvage of compromised mastectomy skin flaps, which is a common reconstructive challenge.
Can you give a specific example of a mastectomy flap case?
Sure. The 2016 case report by Copeland-Halperin et al. Describes a patient with a history of breast irradiation who unfortunately suffered mastectomy skin flap ischemia after undergoing a nipple-sparing mastectomy and immediate reconstruction. She received 15 treatments of hyperbaric oxygen, starting at 2.0 atmospheres absolute on post-op day 1, initially twice daily for 2 days, then daily sessions. The report states this resulted in complete mastectomy flap salvage and allowed her to complete her reconstruction successfully. It's a good, detailed example and a very relevant clinical context.
What about use in pediatric patients or specific types of trauma? Is there evidence there?
Yes, there is. Camison et al., in a 2020 retrospective chart review, specifically demonstrated the utility of HbO2 for salvaging large composite grafts, bigger than 1.5 by 1.5 centimeters, in pediatric craniofacial soft tissue trauma. They looked at 9 children, average age around 8, with challenging defects like ear and nose amputations or scalp avulsions. HbO2 was initiated immediately after surgery and continued daily for 8 to 10 days. At an average follow-up of about 30 months, they reported greater than 80% graft take, satisfactory cosmetic results, and minimal residual deformity.
So effective in kids with severe facial trauma. Any other pediatric examples?
Shum et al. Published a case series showing utility in managing various complications after pediatric craniofacial reconstruction, like hematoma, venous congestion, or even hardware exposure. 42 patients, mostly teenagers, received HbO2, and 41 of them recovered without needing additional surgical intervention. It highlights a potential role for HbO2 in managing post-op problems beyond just primary flap failure.
And you mentioned earlier an interesting example of preventative or preemptive use.
Yes, the study by Nieminen et al. In pediatric hypospadias repair is quite unique. They looked at using HbO2 before the second stage of a stage tubularized autograft STAG repair to try and prevent graft contraction, which can be a problem. 7 patients received HbO2 5 days a week for 4 weeks preoperatively, plus 10 sessions postoperatively starting on day 1. Compared to 14 controls who didn't get HbO2, all the HbO2 patients had good graft take with no graft contraction, whereas 6 of the 14 controls, 43%, did have documented graft contraction. This is a really important example suggesting a potential prophylactic role for HbO2 in certain high-risk scenarios, not just as a rescue therapy.
That's a different way of thinking about it. And just to bring it right up to date, a recent case from 2022.
Simon and Bach published a case series in 2022 looking at soft tissue wounds, including a 73-year-old smoker who developed distal flap necrosis on a nasal dorsum advancement flap after Mohs surgery for basal cell carcinoma. Hyperbaric oxygen therapy was started postoperatively, involving 20 daily treatments. They reported complete resolution of the nasal tip necrosis within 5 weeks. Just another recent clinical example showing its application for necrosis that develops after surgery.
Okay, let's try to summarize this wealth of clinical evidence then. We have the solid foundation of the Level 1 Perrins randomized trial showing significant benefit for compromised grafts. We have Level 2 evidence from the Roche trauma cohort study demonstrating reduced graft and flap complications even in severe injuries, and the zoo review pooling smaller trials that supports benefit and reinforces the importance of early 72 hours initiation. And then we have this large body of Level 4 evidence, numerous case series and case reports that provides extensive real-world context, consistently highlighting the critical factor of timing, like in Bowersox and Waterhouse, suggesting the utility of objective measures like TSACOM, Mathieu, Larson, and demonstrating success across a wide variety of clinical scenarios, patient populations including pediatrics, and even suggesting potential preventative roles.
That's a good wrap-up. And based on the totality of this available data, the single randomized controlled trial, the supporting non-randomized cohort studies, and the consistent findings across numerous case series, the use of hyperbaric oxygen therapy for the salvage of compromised grafts and flaps should be considered a Class 1B intervention according to the American Heart Association evidence-based guidelines classification system.
Can you explain exactly what a Class 1B recommendation means in practical terms for us as clinicians? What does that designation signify?
Sure. A Class 1 recommendation means that the intervention is generally considered useful and effective, and that treatment is indicated. The B refers to the level of evidence supporting that recommendation. Level of evidence B means the conclusion is supported by evidence from a single, good-quality randomized trial. That's the Perrin study here, and multiple non-randomized studies, which includes the Level 2 cohort studies and the wealth of Level 4 evidence we discussed.
So it means there's strong support, just not necessarily from multiple large randomized controlled trials.
Precisely. It indicates that based on the available evidence, the consensus is that the potential benefit of using hyperbaric oxygen therapy in these specific compromised scenarios far outweighs any potential risks. It essentially moves this therapy from being experimental or anecdotal into being a recommended part of the clinical practice pattern for managing these challenging situations.
That's a pretty robust endorsement based on the collective literature we've reviewed.
It really is. It reflects a significant body of accumulated evidence over decades.
Okay, let's do a quick mega recap of the entire evidence base we've just explored. We started with the animal studies, which provided those crucial foundational insights into how HBOT works, things like promoting microcirculation and angiogenesis, pushing oxygen deep into hypoxic tissue, and importantly, mitigating ischemia reperfusion injury and modulating inflammation. Those studies consistently hammered home the critical importance of prompt initiation and the need for sufficient oxygen partial pressure achieved only under hyperbaric conditions. Then we moved to the clinical evidence. The landmark Level 1 Perrin's trial showing significant graft salvage. Level 2 evidence supporting reduced complications and severe trauma and highlighting the value of early timing. And then that extensive body of Level 4 case series and reports showcasing real-world success across diverse scenarios, reinforcing the timing principle again and again, suggesting the utility of objective tools like TCOM and showing benefits in specific populations like pediatrics and even for prevention. And all this culminates in that strong Class 1B recommendation for using HBO2 as an adjunct for compromised grafts and flaps.
That covers the why it's used and the what works based on the evidence. Now, perhaps we should briefly touch on the practical how, the clinical management, and some key considerations when you're actually implementing hyperbaric oxygen therapy for these compromised tissues in your patients.
Good idea. Based on the clinical experience in the studies we've discussed, what are the typical treatment parameters usually employed? Pressure, duration, frequency.
Hyperbaric oxygen treatments for this indication are generally administered at a pressure ranging between 2.0 and 2.5 atmospheres absolute, ATA. The duration of each treatment session, the time spent at pressure breathing oxygen, usually falls somewhere between 90 and 120 minutes. Now, the frequency, that can vary somewhat. It depends on the hyperbaric facility's protocols, the patient's overall medical condition and tolerance, and importantly, the perceived urgency and severity of the tissue compromise.
And just to reiterate, if there's a suspected mechanical cause, like a clotted vessel in a free flap, what's the priority?
As we noted earlier, and it bears repeating, any mechanical causes of compromise that are surgically correctable should absolutely be addressed prior to initiating, or sometimes concurrently with, hyperbaric oxygen therapy. HBO2 is an adjunct. It's designed to support tissue struggling due to diffuse issues, microcirculatory problems, or to help recovery following surgical correction. It doesn't replace the fundamental need to fix a correctable mechanical problem if one exists. Take the patient back to the operating room first, if needed.
Okay. Is there a single, universally agreed upon optimal treatment regimen, like the exact pressure, duration, frequency, number of treatments that applies to all compromised tissues?
That's a key point. Currently, there is no definitive consensus on one single optimal hyperbaric oxygen treatment regimen that applies universally across the board to all types of compromised flaps and grafts, given their diverse causes and characteristics. We saw some variability in the protocols used in the studies we discussed. While one animal study by Weber et al. Suggested twice-daily therapy might not offer additional benefit over daily therapy, this hasn't been definitively confirmed in large clinical trials in humans yet. So there's still some variability in practice.
So treatment regimens involve some clinical judgment based on the specific situation and response. How do we manage the situation if, unfortunately, despite initial treatment, the tissue still fails or significant portions are lost? Does HbO2 have any role then?
That's an important consideration. Should the compromised graft or flap ultimately fail despite receiving initial hyperbaric oxygen treatments aimed at salvage, the therapy may still be continued, but with a different goal in mind. In this situation, you might continue treatments to help prepare the compromised wound bed for a subsequent salvage procedure, like a new graft or flap reconstruction. Here, you're using HbO2 more as a wound bed preparation tool to improve the oxygenation, reduce bacterial load perhaps, and enhance the overall health of the surrounding recipient site tissue, making it a more viable and receptive environment for the next reconstructive attempt.
And assessing whether the tissue is responding initially or deciding when to switch goals should be a team effort.
Absolutely. The initial diagnosis of compromise, the decision to initiate HbO2, and the ongoing evaluation of the response to therapy should always be a multidisciplinary effort. It requires close collaboration and communication between the hyperbaric physician, who manages the therapy and the chamber environment, and the plastic surgeon or other reconstructive specialist, who has intimate knowledge of the specific tissue transfer, the surgical issues, and the patient's overall reconstructive plan and goals.
Reaffirming that point that came up so often in evidence, timing is key. Can't emphasize that enough.
You really can't. To be maximally effective for salvage, hyperbaric oxygen therapy should be started as soon as signs of flap or graft compromise appear. The earlier you intervene by boosting oxygen delivery to those struggling cells, the greater the chance of salvaging tissue before irreversible ischemic damage occurs. Delay reduces the likelihood of success.
And how do we objectively assess viability and monitor the response over time beyond just looking at it?
While clinical judgment, observing the tissue's color, capillary refill, temperature, bleeding on pinprick is obviously essential, and the first line, flap and graft viability can also be assessed and monitored using a variety of non-invasive and sometimes invasive techniques. As we mentioned, this includes transcutaneous oximetry, or TCM, which can quantitatively measure tissue oxygen levels at the surface, both at baseline and in response to oxygen challenges or HbO2 treatment. Laser Doppler studies can also provide objective data on microvascular blood flow. Using these tools can help confirm clinical suspicion, quantify the severity of compromise, and objectively track the response to therapy over time.
You mentioned there's no single gold standard regimen, but based on clinical practice and published reports, are there common patterns or paradigms that tend to be followed?
Yes, based on a meticulous review of the published literature and common practice patterns, while a definitive gold standard is lacking, the regimens used thus far often tend to follow a general paradigm. This frequently involves initiating treatment with twice-daily sessions, often at 2.0 to 2.5 atmospheres absolute for 90 to 120 minutes each. This initial intensive phase, usually for the first few days or until clear improvement is seen, is typically followed by transitioning to daily treatments once the area of concern proves to be more viable and hemodynamically stable. The total number of sessions will then vary based on the continued clinical response and the specific indication.
And using those objective measures like TCM seems particularly helpful in guiding those transitions and decisions.
It really is. Incorporating objective measures like TCM or laser Doppler whenever possible and practical is valuable. It helps in assessing the initial viability, determining if the tissue is responding physiologically to the hyperbaric oxygen, and monitoring progress. It helps provide a more standardized marker for response to therapy and can reduce the reliance solely on subjective clinical assessment, which we know can sometimes be prone to interpretation bias.
The source material includes a very helpful flowchart, Figure 3, which tries to summarize this clinical management process for compromised tissues. Could you walk us through the decision points in that flowchart?
Sure, Figure 3 provides a nice visual algorithm. It starts at the top with suspected tissue compromise. The first decision point asks, is it a flap or a graft? If it's a graft, it leads down the graft compromise path. Here, the flowchart rightly emphasizes prevention strategies first, noting the importance of ensuring an adequate wound bed and avoiding inappropriately large composite grafts. If compromise still occurs, it moves towards treatment. If the initial issue is a flap with its own intrinsic blood supply, it leads down the flap compromise path. This path then further differentiates between free flap compromise and random or axial flap compromise.
What's the key step for free flaps?
For free flaps, the critical next step shown is asking. Operative exploration rules out mechanical causes. This reflects the high likelihood of a technical issue needing surgical correction. If the answer is no, a mechanical cause is found or suspected, the path correctly directs to surgical treatment first. If yes, no mechanical cause found or already addressed, then you proceed down the algorithm. For random or axial flaps, the chart again emphasizes prevention, avoiding large random flaps, violating ratios, avoiding tension, and then moves to the main treatment pathway.
So once mechanical issues are addressed or ruled out, or for random axial flaps, where diffuse ischemia might be the primary issue, all paths converge.
Yes, the pathways for compromised flaps, post-exploration if needed, and compromised grafts then converge. The next critical step, highlighted prominently, is start hyperbaric oxygen treatment as soon as possible. Following the initiation of HBOT therapy, the flowchart poses the key question. Clinical resolution of graft or flap compromise. If the answer is yes, the path logically leads to stop hyperbaric oxygen treatment. If the answer is no, meaning the tissue continues to struggle or fails despite HBO2, the path directs to continue hyperbaric oxygen treatment, but now with the goal explicitly stated as to optimize wound bed for salvage reconstruction. It clearly lays out the decision process based on the evidence.
That's very clear. Now, briefly, what about utilization review and cost considerations? These treatments aren't without process and expense.
Right. Regarding utilization review, the source notes it's typically required after about 20 treatments when HBO2 is being used primarily to prepare a recipient site, like an irradiated bed, before placing a flap or graft. Although in those cases, the indication might be better classified under the underlying problem, like radiation necrosis. Utilization review should also generally be employed following 20 treatments after a flap or graft has been placed and is being treated for compromise to ensure continued medical necessity based on response.
And the cost impact. Is it worth it?
This is a really important point. Failed flaps and grafts are not only devastating for the patient physically and emotionally, but they are also extremely expensive for the healthcare system. They lead to prolonged hospital stays, increased need for intensive care, multiple additional operations, and significant morbidity. The argument is that by helping to salvage potentially failing skin grafts, pedicle flaps, random flaps, composite grafts, and especially high-value free flaps, adjunctive hyperbaric oxygen therapy can substantially reduce these enormous financial, physical, and mental costs. It does this by minimizing or even eliminating the need for secondary surgeries, avoiding the morbidity associated with alternate donor sites, and getting the patient healed faster. So when used appropriately in the right patients, it can be very cost-effective by improving outcomes and reducing the overall burden of care.
That economic perspective is crucial too. And finally, we should acknowledge the source material credits the important contributions of pioneers in this field, like William A. Zamboni, MD, FACS, to earlier editions of the review that informed much of this discussion.
Indeed. His work, particularly on ischemia reperfusion, has been foundational.
Okay, so we've really journeyed through the evidence today, haven't we? We started way back with those fascinating insights from the animal models, which revealed the cellular and microcirculatory mechanisms, how hyperbaric oxygen therapy promotes angiogenesis, improves oxygen diffusion, modulates inflammation, mitigates that critical ischemia reperfusion injury, and those studies consistently underscored the importance of prompt initiation and sufficient oxygen partial pressure.
Yeah, and then we moved to the clinical studies, navigating the hierarchy of evidence. We saw the landmark Level 1 Parents trial demonstrating significant graft salvage. We reviewed the Level 2 controlled cohort data showing reduced complications and complex trauma reconstructions, and the systematic review supporting prompt initiation. And we explored that wealth of Level 4 case series and reports that provide invaluable real-world context, reinforcing the critical importance of timing, highlighting the potential value of objective measures like TCOM, demonstrating success in diverse clinical scenarios and patient populations, and culminating in that strong Class 1B recommendation.
We've also discussed the practical aspects of clinical management, the typical treatment parameters, the absolute necessity of addressing mechanical issues surgically first, the current lack of a single consensus regimen but common practice patterns, the potential role of HPO2 in wound bed optimization even after failure, the vital importance of multidisciplinary care, and the value of using objective measures to guide therapy. And critically, we've reinforced that resounding message from all levels of evidence. Initiate therapy as soon as signs of compromise appear to maximize the potential for salvage.
It's clear that hyperbaric oxygen therapy holds a well-supported and genuinely valuable role as an adjunct in our toolkit for managing compromised tissues in reconstructive surgery.
Definitely. But here's a final provocative thought for you, the specialist clinician listening today, to perhaps mull over. While the evidence strongly supports using hyperbaric oxygen therapy as an adjunct, especially when initiated early, the acknowledged lack of definitive consensus on the optimal specific regimen, the precise combination of pressure, duration, frequency, total number of sessions, when applied across the incredibly diverse range of etiologies, tissue types, and patient factors we encounter every single day, suggests that our understanding and application can likely still be refined. How can you, in your own practice, potentially contribute to this refinement? Maybe through meticulous data collection on your patients, participation in prospective registry studies, or other collaborative research efforts. How can we collectively build upon the strong evidence foundation we've explored today to help define those more precise, perhaps even personalized, protocols for the future?
That's a great point. It's definitely an exciting area where continued clinical experience, careful observation, and further well-designed research can continue to optimize how we use this valuable tool to improve patient outcomes even more.
Absolutely. Well, thank you for joining us for this deep dive into hyperbaric oxygen therapy for compromised grafts and flaps. We sincerely hope this detailed look at the evidence and its practical implications has been valuable for your practice.
Thank you. It was a pleasure to discuss it.